Good morning, everyone. I'm Ginny Wise, the Senior Vice President for Advancement at Tulane University. Thank you for joining our third Plug-in to Tulane event. This is a series of ongoing webinars designed to connect Tulaneans around the globe in our new virtual world. Each week, we will feature a different Tulane faculty or staff member with a focus of the effects of COVID-19 on their area of expertise. We will have time for Q&A later in the webinar. Please enter any questions in the chat function and we will get to as many of them as possible. If you are on a computer, the chat function is available at the bottom of the screen. If you're on an iPad, the chat function is within the participants area at the top of your screen. It is now my pleasure to introduce Dr. Richard Oberhelman, Professor and Chair of the Department of Global Community Health and Behavioral Sciences at Tulane's School of Public Health and Tropical Medicine. He is also Director of the Tulane University Office of Global Health. Dr. Oberhelman is a board-certified pediatrician and pediatric infectious diseases specialist with more than 30 years of experience in applied and clinical child health research. He focuses on infectious diseases in children from resource-poor areas, with emphasis on the detection, treatment, or prevention of an array of illnesses. He also directs several NIH-funded international training grants. Join me in welcoming Dr. Richard Oberhelman.
Thank you. Thanks very much. I appreciate the introduction. Today, I'd like to give you kind of a overview from a public health perspective of the COVID-19 pandemic, starting with a little bit about the virus, the origins of the virus. Then we'll talk about some of the tools and data that we as public health professionals use in our work monitoring the epidemic and the impact of interventions. And then I'll wrap up with talking about some of what Tulane is doing to address this pandemic locally and internationally. So let's see. Okay, I think now I have, there we go. All right, so COVID-19, this is now a familiar name for the disease caused by a novel coronavirus. Coronaviruses are viruses that actually look like a crown. You can see this pictorial representation of coronavirus. It was first detected in China and now is in more than 180 countries around the world. So the names are a little confusing for some people. COVID-19 is actually the name of the disease, CO standing for corona, and VI for virus, and D for disease, and the 19, of course, for 2019. The virus itself, we know by the name SARS. SARS is severe acute respiratory syndrome. This is the second SARS virus. You may recall that there was an earlier epidemic of a SARS virus that was mostly in the Far East. That epidemic happened in 2003 and didn't have near the impact of the current SARS-CoV-2 epidemic. So this is the second SARS coronavirus. We are very familiar as public health and infectious disease professionals with the coronaviruses. There are a lot of seasonal coronaviruses that are usually pretty benign. They cause common colds and usually are not terribly serious. These seasonal coronaviruses that are listed on the left-hand side are different from the epidemic coronaviruses. The SARS viruses and the Middle Eastern respiratory syndrome virus, another coronavirus that caused severe mortality in that part of the world. The origins of the two are actually quite different. So the SARS, oh, we'll have to go back one. The SARS coronavirus 2 that causes the current pandemic is probably a virus that originated in bats or in other types of animals. We know that coronaviruses frequently circulate in dogs and cats, and these typically only affect dogs and cats and don't affect people. But occasionally, some of these animal coronaviruses will jump from species to species, and that jump can result in exposure to a virus that we really have little experience with. The reason that we don't have such major epidemics from influenza is that we've seen flu viruses, even though some parts of the flu virus each year are different, other parts are pretty much the same. These coronaviruses that jump from animals tend to be so different from what we've seen before that they can elicit some very intense immune responses and some very intense disease. We also know that there are certain groups of people that have higher risk of coronavirus severe illness and also higher risk of death. Older adults starting around the age 60s and then going up with greater risk in the 70s and 80s, which I'll show in just a moment. And then some of the chronic medical conditions that you've heard about in the news: heart disease, diabetes, obesity, and chronic kidney disease seem the ones that are particularly important in causing bad outcomes with this virus. So this is an interesting depiction we call a heat map. It's a map where the size of the circles are proportional to the size of the outbreak or the total number of cases reported from each country. And I'm showing this to illustrate several important facts. First of all, we realize that this started in China, and it might be easy to think that the size of the epidemic in China is about the same as what we saw in Europe and in the United States. But here, this is what gives you one idea that what we're now seeing in both Europe and in North America is much more intense than the original epidemic in China. So it's certainly something that we have to take very seriously. You can also get an idea from looking at the jump in the total numbers of confirmed cases, comparing the numbers in March and the numbers as of April 10th, as of Friday, and the numbers of confirmed deaths. The mortality rate, which is the proportion of deaths over confirmed cases, is a figure that it changes a bit. You'll see that there's some differences based on age group, and you'll also notice that there's a lot of variation depending on how many confirmed cases there are. And that depends a lot on testing. And we'll talk about testing in just a few minutes, because if you don't test, you're not going to really be able to confirm cases. So in the United States, we have a similar situation where the number of confirmed cases has jumped tremendously from about 3,000 in mid-March to close to 500,000 now in mid-April. And the confirmed deaths have also jumped dramatically as well. Our mortality rate is the mean mortality rate for all age groups, but this is not distributed equally across different age groups, as we'll see in a moment. This is what we call the epidemic curve. You hear a lot about flattening the curve, and this is the type of curve that we want to flatten. It's a depiction on a day-by-day basis of the number of new cases of coronavirus that are being reported. And you can see that the onset of the epidemic, the cases reported in mid-February, which correspond to the Western Pacific, are not nearly as many as the number of cases reported from Europe, starting in March. And then starting in early March, we started to have cases in the Americas. New Orleans was one of the first cities impacted by the coronavirus epidemic. Our first case was reported on March 10. And also, we're reflects transmission that was probably going on for a couple of weeks before that first case was actually identified. So this is another tool that we as public health professionals, particularly the epidemiologists, refer to. This is the reproduction number, so, or the R sub 0. So the R0 is a value that we look at that measures how contagious a virus is. And it's a statistical calculation of how many people someone who has COVID-19 will be infecting. And the general estimates, the estimates from the CDC, from the World Health Organization, in most populations seem to be about 2, meaning that every person with coronavirus typically infected 2 others. Then if those 2 people go on to infect 2 more, and then each of those goes on to infect 2 more, you can see how this rapidly increases. So what we have is not considered a linear growth, it's a logarithmic growth, or a growth by multiples each time, which can lead to the sort of rapid increase in number of cases that we saw. The good news is that a lot of countries now are flattening the curve. They're actually bringing their case numbers down. Italy was one of the worst case scenarios in Europe. Now, after aggressive interventions, particularly in the northern part of Italy, you can see that their curve, which here is shown as of April 10, is now going down. So that's great news. And also the curve for the United States, which is an evolution, because as I just mentioned, the curve is in different phases at different parts of the United States. New Orleans is starting to see a plateau and the initial signs of a downturn, which we were really hoping for. New York City is also seeing a bit of a plateau, but the middle part of the country that hasn't really been as exposed is going to be likely the next wave in this pandemic. So here's a depiction of the coronavirus counts in Louisiana. You can see the total number of cases is now starting to go down. This is a moving average, and you can see the daily figures there where there's a lot of up and down. And you see that one day where there was a huge number, over 2,000 new cases reported in a single day. A lot of that variation really depends on the laboratories, because as you've heard, lab testing has been a limitation. A lot of the laboratories will pool their samples, run a whole lot at once, and when you have release of maybe a week or 2 of results all at once, you see these big spikes. So the curve is actually a 7-day average, where they take the last 7 days either side and average those, and so you get a smoother curve, and you can see that we're now headed in a downward direction, both in cases and deaths. The mortality, we talked about the difference by age group, and you can see that under age 50, the mortality is very low. Compare this to the mortality of influenza. Influenza, which is a disease that we're very familiar with, that we see every year, the mortality overall is about 0.1%. So one person per 1,000. So this is several, even at an average mortality of 2 to 3%, which seems to be about the mean. It's much higher than flu. And you can see that it's skewed with higher mortality in older age groups. And a lot of this is also different from country to country. We're seeing some variation in those figures as well. Compare those mortality figures to the mortality from the other epidemic coronaviruses, SARS and Middle Eastern respiratory syndrome. You can see they're much, much higher. So this certainly is better than any of those scenarios, and certainly less than, much less than influenza. So the mortality also varies a lot by country. Some of that has to do with the age distribution of the population in that country. And you can see here that A lot of the European countries, especially Italy, are reporting mortality rates much higher. This is deaths per 100,000. I'm sorry, this is not deaths per 100,000. This is the case fatality ratio for observed cases and numbers of percent of deaths. Certainly, we're not seeing mortality rates of 12% in the United States. And I don't really think they're seeing that high in Italy either. And again, this is partially a reflection of the number of tests and the number of true confirmed cases, which is definitely challenging because the number of tests available has been limited in many places. So the other tricky thing about this virus is the transmission. It's spread largely by the respiratory route, meaning that people who are sick, who are coughing, sneezing, can transmit the virus in their respiratory secretions. It's a very transmissible virus, which means a lot like measles. Measles is another one that's very transmissible. So it's difficult to contain if you're sick and you're not wearing a mask. So that's why masks are really important for people who are sick. And just in general, it's important for people to wear masks in public because we now know that many people who have the coronavirus don't have symptoms. So these, what we call asymptomatic, people who are infected but don't have but don't have symptoms, or who really haven't started their symptoms. Their symptoms may start a day or two later. Can also be sources of infection. So that's why public health agencies have been so adamant about social distancing and about the importance of wearing masks, which is now recommended in public. So testing is done on specimens from respiratory secretions. So usually that's collected with a swab specimen in the nose. It's done by a molecular test called PCR. This is a modern technique that we use for detecting many types of infectious disease viruses. These are performed by the Center for Disease Control as well as state health departments. But now there's been a big increase in the number of commercial labs who've developed their own PCR tests, who have had PCR tests approved by emergency use authorization. So FDA is allowing a lot of these tests to move forward, even though they haven't fully evaluated them, which is increasing the availability of testing to a much larger population. So that's really needed, and we'll talk about in just a moment about how the availability of testing also impacts our ability to bring the epidemic under control rapidly. So how do we slow down the progression of epidemics like COVID-19? Well, these are the public health measures that you probably all know as well as I do, because there's been so much attention in the media and through public health agencies to get the word out. So these include improved hygiene, so washing your hands frequently. Washing with soap and water is just as good, in fact, actually better than hand sanitizer. So there's been a big rush on hand sanitizer, but soap and water work just as well and better. Quarantine or isolation of people who are known to be infected or who may be infected. So the difference in those two terms, they look similar, but they're slightly different. Quarantine means if someone's been exposed to a person who is known to have coronavirus, and who may be harboring the infection but is still well and not showing signs, those people may be recommended to separate themselves for a period of time up to 2 weeks to prevent spread to others. And this is what we call a quarantine period. Isolation, on the other hand, is people who are known to have coronavirus infection, who are sick from it and who are definitely contagious, so they need to be isolated away from others to prevent spread until they become well. So having people with respiratory symptoms wear a mask and stay at home from work is really important. initially getting that message, if you're sick, stay home, don't try to work if you're sick, was hard to get across. But now I think people really have gotten the message. Having people who wear a mask, wear a mask if they're outdoors and they may be near someone with respiratory symptoms. And that's important because if you go to the grocery store, you don't know if you happen to turn down the other aisle, you may be walking by somebody who's coughing and you don't expect that person to be there, but there they are. So if you have a mask, then it's a bit of extra protection. And then limiting contact with people who might be infected with COVID-19 or by social distancing. And that's a bad term. Health don't like social distancing as a term because it's, what we really are talking about is physical distancing. We don't want to socially isolate ourselves, but we want to physically isolate to prevent spread of infection. So prohibiting large group meetings, working from home, spacing people with 5 to 6 feet between them, and restricting travel from high impact areas are some of the important public health measures. So yeah, the concept of social distancing is really just to do what makes common sense. So one way to think about social distancing, this is an analogy that one of my colleagues in Peru, who's done a lot of educational podcasts, has been using. Think about going to the movies, and if everyone leaves the movie at the same time and the lines for the restroom are going to be really long, but if they control the departure, if only 3 people can leave at a time, and then some people have to come back before another 3 people can go, then there's less congestion. And that's really what social distancing is all about. We have a certain capacity to deal with severe coronavirus infection, capacity based on number of hospital beds, based on number of ICU beds, and most importantly, perhaps based on the number of ventilators, because severe patients do need those very high-tech ventilators. So if we have the same number of people who become ill, but they're spread out over a period of time, then the system is better able to handle them. We're able to understand the transmission dynamics. We're able to develop interventions like vaccines, but don't hold your breath on vaccines right away. It's, as Dr. Fauci has said very eloquently and said many times, it's going to be at least a year, if not more. I'm not aware of any vaccine that's come out after 1 year, but people are working feverishly on, bad term, but we're working very hard on this vaccine, and so it's probably will come out in record time, but will likely take a year to a year and a half. We can also determine the medications to reduce symptoms and prepare the infrastructure and medical personnel needed and educate the population. So here's what we mean by flattening the curve. So if you have the same number of people who become ill, but they all become ill in a shorter amount of time, then the peak numbers go very high. And so that's more than the system can handle. But if you reduce the height of the peak by the social distancing and the methods that we have, you reduce the number of patients at every point in time, and the epidemic remains under better control. It does actually take a little bit longer with measures. You know, that's something that people may not fully understand, that if you implement control measures, we may take longer to get through this than if we didn't do anything. But of course, the consequences of not doing anything is that many more people get sick, many more people die, and nobody wants that. So we are doing much better if we flatten the curve and take a little bit longer. This is a nice depiction that was published in the Times-Picayune, and we can see The number of deaths, this deaths is one of the most important markers because it's a reflection of the total prevalence of the disease in the community. And this is a chart is a little hard to interpret immediately because you can see that the number of deaths per day is shown on a logarithmic scale on that side. So the distance between 0 and 1 is not that different than between 1 and 10, and then between 10 and 100. So the scale gets progressively larger as you go up. This is showing the number of days since the first COVID case was confirmed and looking at the total number of deaths per day. And so it's a curve that's important to try to get down and to flatten and bring under control. So you can see the numbers for Louisiana and the numbers for New Orleans look particularly good here. New Orleans, you can see that we implemented controls pretty early now it appears that we've implemented them quite effectively because the number of cases has fallen, the number of new cases has plateaued, the number of deaths has plateaued. But now we need to keep that up. We're not ready to declare victory and go back to life the way it was. We have to keep those interventions up. And that's the big message that you're hearing from our governor, from our mayor, our public health agencies in New Orleans, as well as the state of Louisiana. You see the state of Louisiana curve is also going up because New Orleans was the canary in the coal mine. That's where we had the first outbreak in the state and one of the first in the country. Now you can see that we're seeing spread within the rest of the state, and so those other outlying areas need to also continue and perhaps ratchet up some of their interventions. You can compare our curve here to the curve for New York City. Of course, New York City has many more cases, and New York City is much, much larger than New Orleans. But our curve is flattened before the curve in New York City, so that's good. And our curve is starting to look like the curve in Hubei, China, in the Wuhan area, where it was effectively under control in early January. So there is some good news on the COVID-19 front. The prediction of how many ICU beds and ventilators we would need in New Orleans has not come to pass. We have not exceeded the capacity. That's really great news. And so we can be very happy. Social distancing appears to be working. I talked about that R0 value for New Orleans. Our R0 value, the number of people infected per case of COVID-19, actually started around 3. We were higher than 2. But now in the past week, it's falling to somewhere in the 1.2 range. What you want to do is get that number down to below 1, because that's when the curve actually starts to fall and go down the other way. We can also learn a lot from places that have been especially successful, and South Korea is one worldwide success story. South Korea rapidly brought a very aggressive epidemic under control by rapid testing, making rapid testing available quickly. They had testing in phone booths. Go in and get tested whenever you wanted. And so having rapid available to testing allowed people to know their status, allowed people to take appropriate interventions, also allowed public health people the ability to track and monitor the epidemic much better. Public information was shared. That's really important. Having that information about where the cases are allows people to respond appropriately. And they implemented social distancing rapidly in South Korea. They were able to actually limit the number of closings because the population was so good at social distancing and wearing masks. It's a culture where masks are not something that's frowned on or that's considered odd. And so I think we can learn from some of their experience by social distancing and using masks. So to wrap up, I'm just going to talk a little bit about what's happening at Tulane. A lot is happening, and a lot is happening very rapidly, and I can't cover everything. And several initiatives I know are in the pipeline and not ready to really talk about yet. But some of the exciting things are at the Tulane Primate Center, researchers are working on the virus. They were able to work on the virus itself with non-human primate models to look at the disease progression, how it's transmitted, and how it specifically affects different Asian populations. And that research is going to be really important to help develop appropriate control and treatment measures. They've also developed a method for sterilization and reusing those high quality, high protection N95 masks that you've heard about that have all been that have been in short supply, and many places have had to come up with novel ways to reuse them. At the School of Medicine, Dr. Tony Hu, who's a Weatherhead Presidential Chair in Biotechnology Innovation and very active in diagnostics for infectious disease, developed a rapid test for COVID-19 that can be used on blood or saliva specimens. So saliva would be a great advance forward. FDA has approved the use of blood plasma. I believe there was a question popping up about the use of what we call convalescent serum or blood plasma from recovered patients. Tulane is one of the academic centers that's pursuing this method. And we actually have a lot of experience. We've used plasma from patients who are recovering to treat aggressive viral infections like Lassa fever, which is a hemorrhagic fever virus that occurs in West Africa and has also caused major epidemics there, as well as for Ebola virus. Dr. Fusco from medicine has been leading a trial on an experimental drug called remdesivir, which is an antiviral drug that has been tried for different tropical diseases and may work in this disease as well. So we're hopeful. You've heard a lot about hydroxychloroquine. Tulane is one of the centers that is also studying hydroxychloroquine. Dr. Gary from microbiology, who's a leading virology expert, has been working on determining the genetic code of coronavirus to determine its origin, which will certainly help us in knowing better how to fight it. You're hearing a lot about mathematical models. Some of the data that I'm showing you is based on mathematical models, and our professors in mathematics, as well as in public health and in the medical school, are improving and refining these mathematical models to predict the spread of COVID-19 and to predict the numbers of cases into the future. In the School of Public Health and Tropical Medicine, we also have a lot of things going on. One of the most exciting is a new publication called Tulane Outbreak Daily. This is a curated daily wrap-up of the most relevant news and data on COVID-19. Claudine Miller, who is an adjunct faculty member in my department and in the School of Public Health, is an intelligence analyst who's applying her experience from H5N1 flu and Ebola and other outbreaks to coronavirus, and putting together a nice summary of some of the breaking news on coronavirus in a daily fashion. So if you go to the School of Public Health and Tropical Medicine website, and particularly to our coronavirus page, you can see how to subscribe and get that Tulane Outbreak Daily. Dr. Kissinger from EPI is also working with the Gates Foundation and collaborators from the med school on a post-exposure prophylaxis study of hydroxychloroquine. So that's the drug you've heard about, and this is not for treatment, but for preventing COVID-19 in people who have been exposed to it. Dr. Fial in the Department of Global Community Health and Behavioral Sciences is assessing the social impact. There's so much social impact of this disease on our communities, and looking at this through her ongoing NIH and Robert Wood Johnson funded studies called the Healthy Neighborhoods Project. We have faculty members from the School of Public Health, including Dr. Julie Hernandez and Janet Wisdom. Both of them have been volunteering with the Medical Reserve Corps and helping with testing at the Mahalia Jackson Theater. And Dean Leviste has been initiating lots of new projects. The first one to be launched is called Sprinting to the Front Lines. And this is a rapid funding mechanism for Tulane School of Public Health students and faculty to respond to the COVID-19 outbreak. So beyond New Orleans, we're also involved in quite a few activities. Ecologist Lena Moses, who's a faculty member in GCHB, Global Community Health and Behavioral Science, as well as in tropical medicine, is looking at community interventions to control epidemics. She has a lot of experience from Ebola and Lassa, and she spent a lot of time in the World Health Organization, or WHO, headquarters, advising and leading a working group from what's called GORN, the Global Outbreak Alert and Response Network. She and I are also working together with our Health Office for Latin America Director, Valerie Paz-Soldan. We're working with fellows who are analyzing data from WHO endorsed protocols and looking at community understanding of control measures. And Dr. Paz-Soldan's also working with several groups of collaborators from other universities in the US and from Peru as well, and leading local initiatives there to improve access to ventilators, improve access to personal protective equipment or PPE, and even on some vaccines and diagnostics, as well as developing podcasts that have been distributed through the South Central Public Health Training Center. So this is just a quick overview of a lot of things that are going on, and I suspect there are quite a few questions, so I'm going to stop and turn it over to Jenny.
Well, thank you, Richard. That was fantastic. I am so proud to see everything that Tulane is doing in this area and to fight this pandemic. So a lot of questions have been coming in. And to those of you who are leaving questions in the chat, just know we'll try to get through as many as we can. And those we can't, we'll try to get back to you after. So the questions are in a sort of, some of the themes are timing, when can we get back to work and how will we do that? Some are about the data and what's tracked. You picked up one of the questions, I think, along the way about the antibody and the use of the antibodies. Right. If any of those sound particularly like areas you want to address, I'll let you, but just going back up to some of the earlier questions were about the timing, I think.
Right.
Says, while mitigation has prevented our health systems from getting overwhelmed, how can Americans return to work if the virus is still prevalent and so few of us are armed with antibodies?
Right. Well, I think the prevalence of antibodies is really a big unknown, and that's been a focus of interest. That's the new focus. If you read the papers, that's pretty much what public health professionals are talking about all over. There are several studies that are in the works looking at antibodies. Our School of Public Health is very interested in looking at and especially at some of the new data on racial disparities in outcomes, and seeing if the antibody data, which really is a measure of the number of people in the community who are infected, whether the outcomes in African Americans are proportional to the number of African Americans in the community who have infection. It's a complicated story because we in Louisiana and in New Orleans have high rates of a lot of those comorbid conditions: cardiovascular disease, diabetes, chronic kidney disease, and dialysis. So we have some of the highest rates in the country. And for that reason, it's not unexpected that we might have higher rates of severe disease and mortality. But trying to tease those all out really depends on knowing how many people are infected. And since so many people have mild symptoms, look at the number of deaths in younger people, very small. And there are many people, even people older. I know of cases in their 60s, 70s who had very mild disease and felt like it was just nothing more than a common cold. So it's very apparently random, but not totally random, as far as the severity on any one individual. So without knowing the number of people in the community who are infected, we can't really know how to advise people appropriately about when is it safe to go back to work. So just to clarify for those who may not understand, the difference in the antibody test really looks at experience of infection. If you become infected, you will have antibodies. They develop over a period of time, and they usually persist for months, if not years. And so it's different from the test for the virus. If you're sick, or if you want to know if you're infected, you get the nasal swab, which is the PCR test that tells you if you're infected. Antibody test, on the other hand, tells you if you've had infection in the past. And it may be in the past month, or it may be a year or two ago. But this virus wasn't around a year or two ago. So people who have infection are people who were infected in this last wave of infection. So to get back to the question about when can we go back to work again and have life as normal, I wish I knew the answer to that. I think public health experts are trying to wrap their heads around that. Looking at the experience from China, what we've seen is that as the amount of time that the epidemic needs to peak is about the same as the amount of time that it needs to go down. And because of that large number of people who are infected but don't have symptoms, we don't want to declare victory too soon. So I'd like to give you good news and say it's going to be a matter of weeks. I think that the truth is we're going to reassess at the end of April. I don't think it's going to be at the end of April. I think there may be some progressive loosening of some of the restrictions. But what we absolutely don't want is for everyone to go back to life as it was as soon as they start to limit restrictions, because then we run the risk of having that second wave, which is what another person was asking about, that once we become looser in our social distancing and our implementation of control measures, we might get a bump. Certainly not as big as the first bump, but we don't want any bump, because this is a bad disease. This is a disease that people die from. We don't want any more people to die. So it's important, as hard as that is, to get that under control. And this is really, it's really hard in low-income communities and in communities with people who are, working in the public sector, we're working in service industry jobs, and many of those people don't have high incomes. Many of them share apartments with groups. Many of them really have to work to keep bread on the table. And so they don't really have the opportunity to social distance as much as people who are better off. And it's a real challenge to know how to address that. And so I think that some of the research that we're looking at is to hopefully find better ways to address those types of disparities.
It's complicated. We appreciate your perspective on it. It's better than ours. So I really do thank you for getting as close as you can to that answer. The question about data, as I mentioned, how difficult is it to get clean data for analysis? Different countries have different reporting standards. Some don't report a death as caused by COVID if there is another health issue involved. Some are choosing to report a rise in pneumonia deaths, for example.
Mm-hmm. Right. And so that is a challenge. And I think that difference in data reporting from different countries is reflected in what you see When I showed the mortality figures, a lot of those with really high mortality figures probably have incomplete data. Not to say that our data are complete. I think that we're definitely struggling to get more complete data. Initially, that limitation on complete data was because there were just not enough tests to go around, and confronted with an epidemic of infectious disease, public health professionals are trained in Tulane and other schools of public health to look at the prevalence of infected people. And the way you do that is with antibody testing. And those antibody tests weren't available until just recently. So now we'll be able to get our handle on that. We also didn't know how many people were truly infected because we didn't have enough tests available to test everybody who needed a test or who wanted a test. And so now some of those limitations are better because tests are more available. So I think the way you get around that variation in data quality or data completeness from one country to the other is not to put a lot of stock in the absolute numbers, but to look at the trends. If as long as they're done the same way, a rapid rise is a rapid rise, and that's what you don't want to have. You want to have the curve flattening, and you want to have it coming down the other way. We in Louisiana actually had better availability of testing than many states early on. I don't know if that's the case right now, but I know early on, we had those drive-through testing centers, which was a pilot program that the federal government set up, and that was great. That offered open to first responders and then to anybody, and so we had a lot more testing quickly than a lot of major metro areas.
We have so many questions and we're not going to get to them all. I will just a few of them, maybe if you could answer one more, have been about the masks, and you addressed this a little bit. It sounds like you're pro wearing the mask. Another one was about the false positives or false negatives in the test. So I don't know if you want to address either one of those before we.
Okay. Well, I'll talk about the masks first. So the recommendation, the new recommendation from CDC and NIH is that people wear masks when they're out in public, and it's complicated because we don't want to take masks away from our first responders or from our healthcare professionals because they really need them. So the recommendation is pretty clear that they don't want you using N95s or surgical masks unless you happen to have a large quantity of surgical masks, but those are really needed more for healthcare professionals. These homemade masks really are more effective in protecting the outside world from you, and this is not, even though it's important, I think our first priority is to protect ourselves. So that's what we're thinking about. But if you come at it from the viewpoint that everybody could be infected, I could be infected, that person next to me in the aisle could be infected. If we all wear masks, then there's an additional layer of protection. Having a mask is better than not having a mask. If you happen to have COVID and you don't know it, having a mask is going to protect all those people around you. And so that's the rationale for wearing masks from a public health standpoint. From a personal standpoint, do you benefit? Not as much as the people around you, but if we all wear masks, then we all benefit. So that's the reason for doing it. The homemade masks don't really prevent these little viral particles that are transmitted in aerosols from getting through. And one of the big distinctions that we as infectious disease doctors make is the difference between droplets and aerosols. Droplets are what transmits a lot of respiratory diseases. When you cough and you sneeze and it's wet and you could feel the drops, from somebody who's sneezing. Those are droplets. Those are heavy, they fall to the ground, they don't hang around in the air. What we're more concerned about with coronavirus, what we call aerosols. They're these little fine, tiny drops that stay suspended. And as time goes on, we've learned that a lot of transmission of coronavirus is by aerosols. And so that's why you know, it's the thinking has changed a bit. And even though these masks don't prevent contact, don't protect you against aerosols, we know it's very contagious. And so anything we do to reduce that is going to be better.
Fabulous. Yeah, did you want to quickly, or any final remarks from you? There was positives that.
I had a question about the sensitivity and specificity of the tests. You know, I think it's, you know, it's something that we have to keep in mind. It's not a reason not to do them, but all tests have a certain sensitivity and specificity, meaning that a certain number of positives are not picked up. Usually it's very small, usually it's less than 1%, but those are out there. And the same with the specificity. Some people who are negative have false positive tests. Now, one of the things we don't know about is how specific are these new tests and these antibody tests as compared to, I mean, for detection of coronavirus, the COVID-19 virus, as compared to other coronaviruses, because there are a lot of coronaviruses in the environment. So I think we just need to do the studies, realizing that, you know, some of the results are going to be false positive or false negatives. But in the big picture, you know, it's important to have that information, and then we'll be able to better advise people as far as interpretation the next time we use the tests, and maybe refine them to be even better. So thank you for your attention. It's a exciting time to be in public health. It's too bad that you know, this is what it took, if I can say, you know, for the people in the country to realize the importance of public health. So I think now people will get it even more, and so it'll hopefully lead to better investment and support for the whole public health community, including schools like Tulane and our great public health institutions in Louisiana, in the US, and around the world.
Well, thank you, Richard. Just so helpful, this information, and the number of questions coming in, and the thank yous and appreciation from folks for your expertise and time. And we do get it, those of us who didn't get it before. And we are very, very grateful for those of you who have taken time to dedicate your careers to this kind of expertise. So
thank you.
For everyone else out there, we've tried to get through a lot of the questions, or at least get to some of the themes that were in the questions. So, and we'll try to respond to anybody that we didn't get specific answers to. These sessions are recorded and are posted on our website. There'll be a link to that in the follow-up. So I just wanted to let everybody know that our next Plug-in to Tulane webinar will be next Monday at the same time. And it is featuring the School of Social Work, the Dean from the School of Social Work, and other folks. And it's the focus is on anxiety and stress caused by this current reality that we are facing. So thank you to everyone who attended, and we hope to see you again next week. There are a lot of resources on our website. Dr. Oberhelman mentioned public health website. I know public social work also has one, and we have a lot of information on the main Tulane website and the alumni website. So thank you to everyone again, and have a great day.